Hi, my name's Ernest Hunter. I'm a quasi-retired psychiatrist, and it's been my privilege to work in Northern Australia for most of the last 40 years. I've been asked to talk a little bit about my career, which I'll keep short, and then to comment on the issue of decolonising psychiatry. And in doing this, I'm giving my thoughts and opinions rather than stating fact, and certainly, hopefully, not repeating dogma. My background is I was born in Western Australia, grew up there, studied medicine in Perth, and then went to the United States where I did my adult psychiatry, child psychiatry, cross-cultural psychiatry, and public health in a variety of different situations. Came back to Australia in the mid-80s. I've worked at the Redfern AMS, undertook research in the Kimberley for about 3 years, which resulted in a book through Cambridge University Press called Aboriginal Health and History, Power and Prejudice in Remote Australia. And for the last 30 years have been working in far north Queensland. About 5 years ago, I resigned from Queensland Health in protest, and that was over what I saw as being the undermining of the salience of relationships in the work we do as clinicians. And I've been able to continue my engagement with remote communities through projects that basically work with schools. This has been a pleasure, a joy, and the last 30 years have been entirely worthwhile. I think that when we start to frame remote Australia and working in that set as hardship, we really do a disservice to the communities of that part of the world, and we discredit what is, I think, an enormous intellectual challenge. So in terms of talking about the idea of decolonising psychiatry, I think that we need to keep in mind what the persistent features of a colonial mindset are. And these involve privilege, a power differential, dehumanisation, which in this context is expressed as racism, and a rationale or justification which gives the legitimacy to those practices. So decolonising, I suggest, is a lot more than calling out racism. And I'd like to paraphrase Australian philosopher Raymond Gaita, who made the comment in his book Common Humanity and elsewhere that it's important for us not only to feel the sentiments associated with opposition to racism or whatever, but we need to understand why we so feel and be able to articulate it. So in relation to the context of the times when that book was written, his point was that addressing the needs of Indigenous Australians is more than feeling good and solidarity, walking across the bridge and support. It's about trying to understand the background that informs those decisions to so act. Colonialism, of course, means many things, and for us now, we need to think about the different eras of colonialism and how that resonates in the current. We've got millennia of empires, followed by the birth of the nation states in the late 18th century, the seeming inexorable rise of neo-colonialism from the 1980s, and now the apparent resurrection of autocracies. So the nature of colonialism is shaped by a range of factors, and relevant to us is the differential between economic colonialism, and here we can think about the plantation economies and mining fortunes reaped in Africa and Asia, and settler colonialism. Think the Americas, Australia, New Zealand, but also Palestine. I don't think it's possible to fully consider what's happening in Gaza and the West Bank at the moment without thinking about this through the lens of settler colonialism, because this necessarily involves displacement and destruction of native peoples or ways of life. And this requires a particular set of ideological frameworks to justify that. And from a philosophical and legal perspective, there's a big difference between the precedents that enabled the British East India Company to control a continent and its economy, and those that underpinned manifest destiny and westward expansion in the United States, and here in Australia, terra nullius. With that in mind, and thinking about the mindset of colonising, I think we can identify a range of different lenses through which you can look at this. One is through being part of the peoples who were colonising powers, Great Britain, France, Portugal, lots of them. The second is to think about this through the lens of native peoples in the nation states that colonising powers came to. The third is native peoples in the nation states spawned by decolonisation, such as the Africas. The fourth is the settler colonial beneficiaries of those processes, think Australia, New Zealand, Canada, the United States. A fifth is the First Nations survivors of settler colonialism in the contemporary times. And the sixth is what's called Fourth World societies. And here an example would be the Amazonian tribes in Brazil and hill tribes in Assam. So in this process, health and health services and science have been involved in different ways. And medicine's been involved in as a profession that's associated with privilege and power, and it reflects and supports the status quo. It's also involved as a discipline that supports the ideological framework to justify political practices implicitly and explicitly. And then medicine as a practice differentially attends to the needs of those representing power structures and the asymmetry in access to services. In Australia, between Indigenous and non-Indigenous people is a case in point. Well, what about psychiatry? Well, there are some examples of psychiatrists who have been enlightened challengers to that space, and an example is Frantz Fanon. But his particular position was probably driven more by his politics and his origins in Martinique, a French colony and slave economy, than it was as a result of his education as a psychiatrist or his experiences as a psychiatrist. There are a lot more numerous examples of people who have supported and refined race-based practices from the disciplines of medicine and psychiatry. In the past, I was involved in genocide studies and lectured in Israel on a number of occasions. And the academic disciplines that were most important in refining the ideology and supporting the development of the killing processes in Europe in the middle of the last century were anthropology and psychiatry. Indeed, it was a professor of anthropology and a professor of psychiatry and a professor of law, I should say, who wrote the book Life Unworthy of Life, which laid the foundation for what was called the T4 program in Germany, the euthanasia program, which through the 14F13 program supplied expertise and planning to the race-based killing in Poland and elsewhere. Those guys, though, are relatively few in number. Far more numerous are those in our professions who might be considered complicit by action or their silence. Well, what about Australia? Well, we certainly have a history of the conflation of political and medical roles in Indigenous affairs, and two examples are the Chief Protector of Aborigines and Chief Medical Officer in the Northern Territory, Cecil Cook, from 1927 to 1937, and in North Queensland, Walter Roth, who was Chief Protector from 1898 to 1906 and who was responsible for the passing of significant legislation. Their roles supported racist thinking, but they were probably acting in their medical roles in what they saw as the best interests of Indigenous people and were, for the time, enlightened. There are, however, also lots of examples of race-based practices, and the best examples of those are communicable diseases, particularly STDs and lock hospitals around Australia, in Western Australia at Bernier and Bazoot Island, what Daisy Bates called the Isles of the Dead, and the lazarettos that were scattered across the north of Australia. There were some non-Indigenous people who were detained because of leprosy, which of course is an introduced disease, but they were very few and far between by comparison to Aboriginal people. And the leprosarium in Derby, the Bungarun, wasn't closed until 1985, and there are about 360 people who are buried there. So we also need to think about discriminatory access and practice, which we see in the disadvantage of Indigenous people generally in terms of accessing particularly specialist services. Psychiatry has a history, though. Up until the 1970s, psychiatric engagement in Indigenous Australia was really almost a holiday affair, what I would call the psychopathology of the exotic. Somebody tripping off to remote Australia during their vacation to write up an exotic paper for a journal. This was followed by the work of people like John Court, who developed the concept of ethnopsychiatry and particularly worked in remote Australia in the 1960s and 70s. And through the 70s and 80s, the work of people like Max Kamian and Barry Nurcombe, which shifted the focus from identifying conditions in remote Indigenous communities and describing them to thinking about why those conditions were common as a consequence of social disadvantage. In the 1980s, that changed, and I suppose I'm lodged in that space, to shifting from asking how do those conditions inform the sorts of problems we see presenting to doctors and psychiatrists, to thinking what are the social and historical factors which entrench and embed those forces. And that's a kind of a political and historical context. Since the 1990s, I think that we've seen a bit of a retreat to the bastions of diagnosis and delivery, and I think that in part reflects protectionism around biomedical turf and commodifying services, and I don't think that this can be understood without considering the wider context of neoliberalism. So neoliberalism treats misery as a commodity. It discounts history, and I would argue that we can't understand the contemporary patterns of psychiatric ill health in Indigenous settings without understanding history. That we have seen waves of substance misuse in the 70s, adult suicide in the 80s, child suicide in the 90s, and psychosis in the thousands, can't be explained by genetic factors. It can't be explained as a consequence of single events. It can only be explained by understanding the way in which the contexts of life, particularly for early development Indigenous settings, have changed. The other thing about neoliberalism is that it enshrines meritocracy and doesn't problematise it. Meritocracy suggests that if you work hard, you'll make it. The obverse to that is that if you're not making, it's because you either weren't sufficiently prepared or you haven't worked hard. And this brings me to one of the most influential authors and papers that I've read, which certainly shaped my thinking. And that was a guy called Eugene Brody, who in 1966 published a paper on cultural exclusion. And the basis of cultural exclusion, this concept, is that there are particular practices, racism, caste system, particular sorts of economic dependency such as serfism, that cement disadvantage, and that when those structural impediments are removed, that other processes take their place which prevent access to the means and opportunities of the wider society. Those means and opportunities are health and education primarily. But along with that goes the supposition that if you're not making it now, it's a consequence of failure of application or lack of qualities. That results in a level of self-blaming. So it's not the big fella's fault, it's my fault. An internalization of failure. So cultural exclusion is a process which has continued long after the structural and legislative barriers have been lifted here in Australia. And that leads me to think about the critical importance of those basic tools of opportunity. And here, thinking about the Canadian philosopher John Ralston Saul. And basically he was saying that in order to provide equality of opportunity, we need to ensure that there is equality of access to the means of opportunity. And those are safe and healthy pregnancies, childhoods that give basic tools and provide the capacity to have a vision of opportunity. We need to get those basics right. So what does this mean for us? Well, I think that as psychiatrists, if we want to be serious about decolonising psychiatry, we first of all have to have integrity in our work. And that applies to everyone, and to Indigenous Australians and other disadvantaged people, as much as those people that we might encounter in private clinics. We need to develop relationships with those people and privilege understanding over diagnosis. I was presented with a difficult situation a number of years ago when I had attempted to set up a hypothetical in a school situation, bringing external agencies in, and I hadn't recognised the intensity of the negative feelings between those agencies. The headmaster ceased it all, got those people to leave and said, look, we're just going to tell you a story and you tell us what to do. And he then presented a 3-generational disaster, alcohol, abuse, etc., and a kid who was running wild. Now, to step back and try and give a diagnosis short circuits understanding. It is a way of concluding the conversation. What I chose to do on that day was to say, well, look, there are 3 generations in this family. Let's look at the world this child grew up in, the world the parents grew up in, the world that the grandparents grew up. If we end up with some sort of diagnosis at the end, albeit, but let's try and understand what's going on. So as a discipline, I think that we absolutely need to know our history. We need to understand its footprint in the present, that in remote Indigenous communities, for instance, the people that most resemble, who walk in the footsteps of the missionaries and the colonial administrators, are police and hospital staff. So it should be no surprise that even though young medical professionals arrive expecting to be embraced as they've come to help, that there's ambivalence. We also need to challenge complicity. That is, that the solution to the enormous health and social health problems and mental health problems in remote Australia are not simply more clinicians and more health workers. When I first arrived in far north Queensland, I was the only mental health practitioner of any kind, or drug and alcohol practitioner, between Cairns and Papua New Guinea. There are now more than 200, and I would suggest that we are not 200 times better off. So, as a profession, some questions or some thoughts or some concluding remarks. How do we as a profession challenge the commodification of misery that's part of the neoliberal transformation of Australian society? This is in the lineage of a colonial mentality. How do we grapple with our real or potential roles in relation to addressing social determinants and wicked problems, like closing the gap? Closing the gap is a very wicked problem, and it's going to take generations. But we've been saying that for 2 generations. How do we understand our own history, and how can psychiatry claim authority in responding and contributing to reconciliation? That's more than a position statement of the college. And to do that, we need to ensure that our representations are based on sufficient understanding of the particularities of Indigenous history and circumstances, not only in relation to thinking about Indigenous people nationally, but as we go out into remote Indigenous communities, we need not only to know about the referendum and various commissions, but we should understand in a more nuanced way some of the background of those local communities. Thanks for listening to this. Cheers.